He was 69 years old, retired, in reasonably good health by most conventional measures. No diagnosed heart disease. No recent symptoms that concerned him or his physician. He woke up on an ordinary Thursday morning feeling, by his own account, completely normal. He lay in bed for a few seconds, then swung his legs over the side and stood up quickly the way he always did. He walked to the bathroom, turned the shower handle all the way to cold, something he had started doing 6 months earlier after reading about the benefits of cold exposure, and stepped in. 18 minutes later, his wife was on the phone with emergency services. I was the cardiac surgeon on call that morning. I scrubbed in, I operated, and he survived. But I have stood in operating rooms after cases with nearly identical circumstances that ended in the opposite direction. Cases where the patient did not make it back out of that bathroom. And what I want you to understand, what I want you to carry with you after everything I say today, is that what happened to that man was not random. It was not an unforeseeable tragedy. It was the predictable biological consequence of a series of very specific mistakes, made in a very specific order, during the most physiologically dangerous window of the entire 24-hour day. Mistakes that enormous numbers of people over 60 make every single morning, without hesitation, without awareness, because nobody has ever explained to them what is actually happening inside their body during those first minutes after they wake up. Let's start with the science, because understanding the mechanism is what changes behavior in a lasting way. Cardiologists have known for decades that heart attacks and strokes do not distribute themselves evenly across the day. They cluster. They concentrate in a specific window. Research tracking cardiac events across large populations has consistently identified the early morning hours, roughly from the time of waking through the first 3 to 4 hours afterward, as the period of substantially elevated risk. The increase is not marginal. It is significant enough to have earned its own clinical terminology. We call it the morning surge. And for people over 60, that surge is steeper, faster, and arrives with considerably less physiological margin for error than it did in earlier decades. Here is what is happening at the biological level. During sleep, the body operates in a reduced demand state. Heart rate is slower. Blood pressure is lower. The nervous system is relatively quiet. The cardiovascular system is, in a genuine sense, recovering. But the transition out of sleep is not gradual. It is a rapid mobilization. Beginning roughly an hour before you are even consciously awake, the body begins releasing cortisol and adrenaline in rising concentrations. These stress hormones are not pathological in this context. They're the body's mechanism for shifting from rest to readiness. But what they do to the cardiovascular system in that transition is significant. Heart rate increases. Blood pressure rises. Blood vessels constrict. All of this happens within minutes, sometimes within seconds of waking. In a 35-year-old with elastic, responsive arterial walls and a heart with full physiological reserve, this surge is managed without incident. The vessels adapt quickly. The system absorbs the demand and stabilizes. After 60, the same surge encounters a different biological landscape. Arterial walls are stiffer. Their ability to expand and contract rapidly in response to pressure changes is reduced. There may be atherosclerotic plaque built up within coronary vessels, deposits that have accumulated quietly over years or decades, producing no symptoms, invisible to the person carrying them. When a morning hormonal wave sends blood pressure climbing and drives turbulent flow through constricted vessels, the mechanical stress on those plaques can cause them to fracture. A fractured plaque triggers the clotting cascade. A clot forming in a coronary artery cuts off blood supply to the heart muscle. That is a myocardial infarction. This is not a worst-case scenario I am describing for effect. This is the pathological mechanism I have seen confirmed in operating rooms more times than I can count. Before you have made a single deliberate choice about your morning, your cardiovascular system is already under its peak daily stress load. Every habit you execute in those first minutes either helps your heart manage that load or compounds it in ways that dramatically increase the probability of something going very wrong. The first compounding factor operates so quietly that most people never connect it to cardiac risk at all. After 7 or 8 hours of sleep, every person wakes up in a state of mild dehydration. This is not a matter of lifestyle or hydration habits from the previous day. It is an unavoidable physiological consequence of respiration. Throughout the night, with every breath, the body loses moisture. By morning, the blood has measurably thickened. Its viscosity, the technical term for how easily it flows, has increased relative to its state the previous evening. For the heart, this change in blood consistency translates directly into increased workload. A pump moving thicker fluid through the same network of vessels must exert greater force with each contraction. And thicker blood carries an additional and more serious consequence. It clots more readily. The proteins and cellular components involved in clot formation are at their highest activity levels in the early morning hours. This is well documented. It is one of the primary biological explanations for why cardiac events cluster so heavily in that morning window. The morning surge in stress hormones, elevated blood pressure, arterial stiffness in older adults, and heightened clotting tendency in thickened blood. These are not independent risks that occasionally overlap. They are simultaneous converging pressures on the same cardiovascular system, happening every morning to everyone over 60 before breakfast. The correction for the dehydration component is almost absurdly simple relative to its importance. A glass of water, room temperature, consumed before anything else, before coffee, before medication, before the phone is checked, begins the process of restoring blood fluidity almost immediately. This single habit, requiring perhaps 30 seconds and no financial investment whatsoever, addresses one of the three major morning cardiac risk factors directly. The practical implementation is equally simple. Place a glass of water on the nightstand before going to sleep. Remove the decision and the effort from the morning entirely. Make it the path of least resistance. This is one of the most consistently high-value, lowest-cost habits available to anyone managing cardiovascular health after 60, and it is one of the least consistently practiced. Now to the cold shower. I want to address this specifically and directly because the cultural momentum around cold water exposure has grown substantially in recent years, and the conversation surrounding it almost never includes the information that people over 60 most need to hear. Cold exposure has documented physiological benefits. Certain forms of deliberate cold therapy, applied in appropriate contexts, have genuine research support. I am not dismissing the practice categorically, but timing is a clinical variable that the enthusiast content promoting cold showers at dawn almost universally omits. The moment cold water makes contact with skin, the body initiates what physiologists call the cold shock response. It is immediate and it is powerful. Blood vessels near the surface of the skin constrict sharply to redirect blood flow toward the core and protect internal temperature. Heart rate spikes abruptly. Blood pressure can jump by 20 to 30 points, systolic, within seconds of cold water contact. This is a substantial, rapid cardiovascular perturbation. In isolation, in a different physiological context, at a different time of day, a healthy body manages it. But in the morning, that cold shock is not landing on a neutral cardiovascular baseline. It is landing on a system that has already been pushed by the cortisol surge. Blood pressure is already elevated above its overnight resting level. Blood viscosity is already increased. Arterial walls, especially in people over 60, are already managing reduced flexibility. The cold shock adds a sudden, violent vascular constriction on top of a system that is already at its most stressed point in the daily cycle. For people with arterial stiffness with undiagnosed or incompletely managed coronary disease, with any degree of plaque accumulation, and a substantial proportion of people in their 60s have at least some degree of all of these, whether they know it or not. That spike can be the precise mechanical trigger that fractures a vulnerable plaque or provokes a coronary spasm. The man whose story opened this conversation had his cardiac event in a cold shower. His coronary arteries were not in catastrophic condition. He was not someone you would look at and immediately identify as high risk. But the combination of the morning hormonal surge and the abrupt cold shock was more than the system could absorb at that particular moment in time. The cold shower was not a health habit in this case. It was the trigger. If cold water exposure is something you value and want to continue, the timing adjustment is straightforward. Begin the shower at a comfortable body temperature warmth, approximately 37 degrees Celsius. Allow the vessels to dilate. Allow blood pressure to stabilize as the warm water does its work. In the final 30 seconds or so, introduce cold. By that point, the physiological environment is fundamentally different. Vasodilation has occurred. Pressure has stabilized. The cold shock response, when it comes, is considerably less severe. The benefit, if that is what you are seeking, is available without the morning risk profile. One small adjustment in sequencing. Genuinely consequential difference in cardiac stress. The way most people physically get out of bed is a more serious cardiovascular issue than it might appear. The typical morning routine involves moving from horizontal to vertical in a matter of seconds. Alarm sounds, legs swing over the side, feet hit the floor, person is upright and moving. It feels like nothing. It is not nothing. When the body transitions from lying flat to standing, gravity immediately pulls a significant volume of blood downward into the legs and lower abdomen. The cardiovascular system must respond to this redistribution immediately, constricting peripheral vessels and increasing heart rate to maintain adequate blood pressure to the brain and vital organs. In younger adults with responsive, elastic vessels and a nervous system that processes and responds to these signals rapidly, this compensation happens efficiently and the person feels nothing unusual. In older adults, this compensatory reflex slows. The vessels do not respond as quickly. The nervous system's reaction time is longer. Blood pressure can drop significantly, in some cases by 15, 20, or more points, in the seconds immediately following standing. This is called orthostatic hypotension, and it is considerably more common in people over 60 than most people realize, because many who experience it either assume the brief dizziness is normal or simply don't connect it to any cardiovascular significance. It is not a trivial inconvenience. Orthostatic hypotension is a leading contributor to falls in older adults. A serious fall, a broken hip, a head injury can initiate a cascade of health deterioration that, in older adults, is far more life-threatening than it sounds in the abstract. Beyond the fall risk, the cardiovascular compensation required to respond to that sudden blood pressure drop forces the heart to accelerate and increase output rapidly, a spike in demand imposed on a system that is already at its morning stress peak. In people with underlying cardiac vulnerability, that compensatory spike can provoke arrhythmia. In more severe cases, it could trigger a cardiac event. The prevention is not a medical intervention. It is a 10-second behavior change. Before standing, sit. Before sitting, take a moment lying on your side. Move through the transition in stages rather than in one rapid vertical lurch. Sitting on the edge of the bed for approximately 60 seconds before standing gives the cardiovascular system the time it needs to begin adjusting to the shift in position. During that seated minute, rotating the ankles, simple circles in both directions, activates the calf muscle pump, which assists in pushing blood back upward toward the heart, supporting circulation against gravity before the full demand of standing is placed on the system. Then stand slowly and remain still for several seconds after standing before beginning to walk. The entire modification takes under 2 minutes. It costs nothing. It prevents falls, it prevents arrhythmias, and in some circumstances it prevents outcomes that no surgical intervention can reverse. There is a medication category interaction that is relevant to a large number of people over 60 and that is insufficiently discussed in the clinical conversations where it should come up. Diuretics, prescribed widely for hypertension, for heart failure management, for fluid retention, work by prompting the kidneys to excrete excess fluid, reducing circulating blood volume and thereby reducing pressure. They are effective medications with good reasons behind their prescription. But as the kidneys flush fluid in response to diuretic medication, they also flush minerals. Among the minerals lost in this process, Magnesium occupies a position of particular cardiac importance. Magnesium is directly involved in regulating the electrical signals that control the timing and regularity of the heartbeat. It plays a role in maintaining stable cardiac rhythm. It supports proper relaxation of the heart muscle between contractions. When magnesium levels decline, quietly, without obvious symptoms, over weeks and months of diuretic use, the heart's electrical system becomes increasingly unstable. The rhythm can become erratic. Palpitations develop. Skipped beats occur. More serious arrhythmias become possible. And because the early morning hours are when the cardiovascular system is already under its greatest daily stress, a magnesium deficiency that might be subclinical during calmer physiological conditions can become acutely significant precisely at the moment the morning surge is placing maximum demand on the heart. People taking diuretics should specifically request a magnesium level at their next blood draw. This is a straightforward addition to standard laboratory panels. The test is simple. The information it provides is not. Identifying and correcting a magnesium deficiency in someone experiencing unexplained morning palpitations or arrhythmias can be genuinely transformative. It is the kind of thing that resolves a problem that might otherwise be escalated through more aggressive, more expensive, and more invasive interventions, if the right question had simply been asked earlier. Exercise in the morning deserves a direct and honest conversation that does not end with a simple endorsement or a simple caution. Physical activity is among the most evidence-supported interventions for cardiovascular health at any age. There is no qualified cardiologist who would argue against regular exercise for people over 60. The recommendation stands firmly, but intensity and timing within the morning context carry clinical significance that the general messaging around exercise rarely addresses. Consider the physiological state that exists in the first 30 to 60 minutes after waking. Cortisol is elevated. Blood pressure is above its overnight baseline. Blood viscosity is still higher than it will be after adequate hydration. Coronary arteries, which supply blood to the heart muscle itself, are still relatively constricted from the morning hormonal environment. The heart is already working harder than it will be 2 hours from now. Launching into vigorous exercise within minutes of waking, without allowing the body time to stabilize, without adequate hydration, without a genuine warm-up, places the heart in a situation where its oxygen demand is climbing steeply while its supply is constrained. Research examining the timing of cardiac events in relation to exercise has found that vigorous exertion in the early morning carries a measurably elevated risk of triggering acute cardiac events in adults over 60, relative to the same intensity of exercise performed later in the day when the body has had time to fully shift into its active physiological state. None of this is an argument against morning exercise. It is an argument for a 20 to 30 minute stabilization period before raising intensity. Walk before anything more demanding. Stretch. Move gently. Let the cortisol begin to normalize. Let hydration begin to work. Let blood pressure find a stable waking state baseline. Then, when the body has genuinely awakened rather than simply being jerked from sleep into exertion, the workout is both safer and, because the muscles and cardiovascular system are properly prepared, more physiologically effective. Now, let's build this into something concrete and actionable, because information without a practical framework has limited value when you're standing next to your bed at 6:45 in the morning. When the alarm sounds, do not move immediately. Stay exactly where you are for the first 30 seconds. Take 3 deliberate, slow breaths, in through the nose, out through the mouth, each cycle long enough that you are genuinely activating the parasympathetic nervous system rather than simply breathing normally. This simple act begins to counteract the cortisol spike before it peaks. It costs nothing and requires no equipment. It is physiologically meaningful. Before your feet leave the bed, reach for the glass of water on your nightstand. Drink the whole glass, slowly before standing. Then roll to your side, push yourself up gradually, and sit on the edge of the bed. Do not rush this. Sit for a full minute. Rotate your ankles in circles, 5 rotations in each direction. This wakes up the calf muscle pump and begin supporting venous return. Then, while still seated, roll your neck slowly side to side, shrug your shoulders, extend your arms above your head. You are warming up gradually, allowing heart rate to rise at a pace the cardiovascular system can absorb rather than demanding full output instantaneously. When you stand, do so at half your usual pace. Place both feet flat on the floor, press upward through your legs, and once upright, stand still for 10 full seconds before taking your first step. Let your blood pressure confirm its new configuration before you begin moving through it. That entire sequence takes approximately 5 minutes from alarm to first step. Those 5 minutes represent a fundamentally different cardiac risk profile than the 2 seconds most people currently spend on the same transition. If you're taking a shower, begin it warm. Allow the body to ease into the experience. If you want cold water, introduce it toward the end. Not at the beginning, never at the beginning. If you exercise in the morning, give yourself at least 20 minutes of gentle, low-intensity movement before raising the demand. The workout is available to you. The body simply needs to be ready to receive it. The man who came back to see me 3 months after his procedure was walking normally, recovering well, back with his grandchildren. The first thing he said when he sat down across from me was a question. He asked why nobody had ever explained any of this to him before. Not his general physician, not the cardiologist he had seen for a routine check 2 years earlier. Nobody. He had been waking up every morning for years, making the same sequence of cardiovascular mistakes, with absolutely no idea that any of it was dangerous. He felt fine. He had no reason to question the routine. That conversation is the reason I am having this one with you now. The morning is the most dangerous window in the cardiovascular day. That is not speculation. It is one of the most consistently documented patterns in cardiac epidemiology. But it is also one of the most modifiable risk factors that exists. Unlike genetic predisposition, unlike decades of dietary history, unlike plaque that has accumulated slowly over 20 or 30 years, your morning routine is something you can change before tomorrow's alarm goes off. Tonight, before you go to sleep, place a glass of water on the nightstand. That single act, costing 30 seconds and nothing else, begins the modification. Tomorrow morning, when the alarm sounds, breathe before you move. Sit before you stand. Stand slowly before you walk. Give your cardiovascular system the transition it is asking for, that it has always been asking for, that it simply never had anyone advocate for it. Your heart has been functioning continuously, without pause, without a single day of rest, for every minute of your life. It has managed every demand you have placed on it, adapted to every challenge, compensated for every excess, without complaint and without credit. The least it deserves is 5 careful minutes at the start of each day. That is the entire ask. And starting tomorrow morning, you have everything you need to give it exactly that.